Hello everybody and welcome back to the interviews for Physio Students and new grads. Today's interview guest is Jack March, otherwise known as the Rheumatology Physio. Today's interview is going to focus very much on rheumatology, and for those of you students, this is going to cover all the things that you need to know about rheumatology, and for those of you who are new grads, maybe some of the things that you might want to focus on a little bit more in your role. So, as always, without further ado, let's roll this great interview. Okay, welcome back everyone to the interviews for Physio Students and new grads. We're back with another fabulous guest, and today we are introducing Jack March. You'll know as the Rheumatology Physio across all social media platforms. Jack is currently a rheumatological clinical lead for Choose Health, and the Physio Matters podcast. Jack is actually operations director. We're going to get into all things rheumatological, as I'm now calling it, and we're going to get started. So welcome to the interviews, Jack.
Thanks, James. Great to be here. We've been planning this for a while, haven't we? And then for one reason or another, we keep deferring it, but it's good to be on the microphone.
It's great to have you on. As you just said there, we've wanted to get this sorted for quite a while. And when I put up my hit list of all those people that we got booked in, you were there I think in August. So we're already a month late. So not too bad. We're doing okay.
That's good. Good effort.
Okay, fab. So I think today we want to cover obviously your experience as a student, because we're going out to students and new grads. We're probably going to be veering on the lines of looking at rheumatology much more than anything else, because that's a big sphere of what you do. I think to begin with, we've got a lot of listeners that are currently just gone back to university as they're watching this, whether they're starting their degree or they're going into second and third year. And then we've also, at the same time, got an awful lot of our listeners will probably be just starting out as their Band 5 posts. So going back, we're just kind of thinking back. I mean, it was 2008 that you graduated, I believe, from the University of Plymouth.
Yeah.
Big up to our alumni there. What was your most enjoyable part of university, Jack?
I was thinking when you sent me the questions, actually, and I was thinking, I didn't really enjoy university learning that much. It wasn't sort of my bag, the way that we did a lot of things. So easily the thing I enjoyed most was placements, unless you include going to sort of student union bar and watching football, which I'm assuming that's not what you're quite referencing. But yeah, placements for sure. I mean, ironically, now that I obviously write a blog and some resources and stuff that I've written, I absolutely suck at written work. I'm really bad at exams, or I was anyway, terrible. But then on the flip side, I was pretty good on placement. So I had this really funny, I don't know what they do now at the University of Plymouth, but we used to get graded quite specifically. And I had a huge disparity between my written work and my placement work, which was really funny. So it's then met somewhere in the middle as sort of tolerable. But I never got on particularly well with the learning environment actually at university, but then managed to make up for all of that on placements. So certainly placements were my favourite.
Yeah, I think it's probably an awful lot of people, myself included, that would kind of agree with that. I think that's quite a common thing as physios and as therapists. I think we're all quite practical people. We're like getting stuck in, and the academic writing is something that I think takes a long time to hone, and some people are natural at it. So if you're watching this and you're struggling with your academic writing, I think you are not alone, and there's an awful lot. And you can do pretty well as a physio and as a therapist without it. So, you know.
Well, I like to think I've done okay, and here we are 12 years later and I'm still doing it. So yeah, and I failed a few things at university and they had to let me have a third go at something and these kind of things. So I wouldn't worry about it if anybody's struggling.
I think it's great for us to hear that, because I mean, you're not the first guest that I've had on that, you know, arguably is gone on to be really quite successful, who has failed things at university. And I think, as the listeners probably know from other things I've done, I'm a great believer in failure being a fantastic learning opportunity. It's not something that should be so negatively looked upon all the time. So no, that's great. Rheumatology at university. Let's get straight onto this one. I noticed you tweeted just earlier today about this to kind of get a bit of feedback.
Yeah, I got nothing. I got a tumbleweed, apart from my brother, who's got a maths degree.
Does that tell you something, though? Does that tell us something
Probably.
about university and rheumatology? So what do you remember from university about rheumatology?
Yeah, I really remember specifically. I don't know what year it was we were in, but we had like these groups that we were in, smaller breakout groups where we do some sort of co-learning. We did one on rheumatoid arthritis, and I don't remember what it contained, but it was certainly, I mean, it could have been 14 years ago, but it was certainly a small amount for what we did. I don't remember us covering rheumatology specifically. I just remember us covering that rheumatoid arthritis. So my memory of it is extremely small. That's what we covered. I was slightly preempting one of your next questions, but I was very lucky that my elective placement, I ended up in a rheumatology department. Not by choice actually, but I then got exposed to a lot of rheumatology obviously there, and that's so I got a lot more learning from that point of view early on. But certainly from my experience, I mean, you're obviously a lot more recent out of the university sphere than I am, so it'd be interesting to see if that's changed at all. But obviously when I was at university, there was no Twitter, Instagram wasn't a thing. I mean, I don't know where I used to get my learning from. It was just traditional CPD talks and courses and things. So we didn't have all this extra access that you guys and the listeners all have. So it was really quite restricted. I mean, I would have seen on MSK placements, maybe the occasional rheumatology patient. I mean, that really would be testing my memory to see if I actually remember anybody who did have rheumatoid arthritis or something. But yeah, very, very small.
Yeah, I think it's quite important. And I think jumping around a bit now, I think we're going to talk about what rheumatology is in a second. But I think it's probably a good point now just to point people in the direction of yourself and the resources, as you said there, that there is a plethora of resources out there for students now. I think sometimes might say there's too much, but it's quite good that actually you've got a really good website, you've got great resources. Just going to point to there some really good books, handbooks and resource books that you've produced, Jack, on rheumatology that can really help students focus on what they need to know. So we'll put links to all of that in the description. So before we go any further, should we just kind of cover, for those who don't know, and if you're a student, we probably just mentioned there, you might not have a great idea of what rheumatology is. In a succinct way, we haven't got two days of one of your courses, but how would you put it into words?
Yeah, so rheumatology is fascinating. So it's really quite broad specialty where they see a lot of musculoskeletal patients, but really, I suppose if you honed in on what rheumatology is from a physiotherapy point of view, then we're dealing with mostly autoimmune conditions. So where the immune system is, for want of a better term, going wrong and affecting the body in various different ways. And so that would be the main sort of aspect of rheumatology. There are other things that rheumatology does and covers with specialty and conditions, and it is very broad. So there are some metabolic bone conditions that it covers. The most obvious one of those is osteoporosis, and then other things, weird and wonderful autoimmune conditions, and auto-inflammatory probably is a better term than autoimmune. So the inflammatory system is affecting the body systems, but because it's the immune system, and obviously the immune system is over the whole body, then there are some really weird and wonderful presentations, and lots of different systems can be affected. So I've worked in a lot of different roles, and certainly rheumatology is the one where they have the biggest grasp across all of the body systems. I would say you know, comparative to orthopedics or neurology or wherever. That it's certainly, I mean, you know, they have to have a really good working knowledge of the gut, the bowels, the skin, the eyes, all of these different systems. And I mean, rheumatologists are really, really good. I mean, it seems silly to say about consultants that they're obviously really good at what they do, but rheumatologists are just another level, I found, and really, really good to work with. So it is fascinating. I don't know if that's answered your question at all, but I think one of the things we should point out, and why I do what I do, is that a lot of these conditions masquerade as musculoskeletal conditions. Yeah. So one of the things that sort of my courses cover and my resources aim to do is to aid clinical reasoning. When someone comes to you with a musculoskeletal presentation, so I mean the easiest one would be back pain or a tendinopathy, to make sure that we're ruling out some sort of central cause, so some sort of inflammatory cause to those symptoms, because a percentage of those patients won't have regular back pain or regular tendinopathy. It'll be caused by their immune system. And I refer to these conditions under the umbrella of red flags, red flag diagnoses. So they're not like some other red flag diagnoses, which would be an emergency or very severe. So they're not like Cauda equina syndrome or a fracture. So we're not sending them to A&E, and it's certainly not like cancer, where we need to know the pathway to go for like a 2-week wait or wherever it is to manage. But they're not physiotherapy problems, these conditions, when they're newly recognized. They're medical problems. They need managing with medicine 99.9% of the time. And as therapists, physios especially, we need to be recognizing that actually we're not the ones that need to be seeing those patients. The rheumatologists are, for proper diagnosis, proper management. There's loads we can do as physios for these patients, but the primary thing that we need to do is get them diagnosed appropriately. So for me, they are red flag conditions because they're a medical problem. So that's a lot of what I spend my time doing, is trying to educate other physios as much as I can about recognizing these conditions.
Yeah, I think that it goes in really nicely to our next question with regards to what your role is, and I think we're starting to touch on the fact of this being a speciality, and we'll probably come back to this and having some ideas as to why maybe it isn't covered so much at university. But going through now into sort of your role, as you've touched on there, what your role is, and we've got a really good one in here, how it differs from other physiotherapy roles, which when I first saw that, I thought it's a bit of a tricky question, but actually when you think about it, it's quite a nice question as well to have. So what is your role and how does it differ?
Yeah, I suppose you can break it down to a few different ways I could answer that question. So I don't now, but I used to work in a rheumatology rehabilitation department, and we would do things like we would educate the newly diagnosed patients on their condition, what they could do, general health, exercise, all those kind of things that they might need to do with their new diagnosis, but also manage longer standing diagnosed patients with regards to their symptom management and things like that. But I also worked in clinic with the rheumatologists. So I was part of the inflammatory spinal pathway. So the GP would refer the patient in with possibly ankylosing spondylitis or whatever it was they thought it would be. And then they would see me. I would do the investigations, MRI, bloods, etc., as appropriate, and then give them to the rheumatologist to medically manage if we thought that they did have that kind of diagnosis. So that it was sort of varied in that role. And when I was doing that, when I first started doing it, which was about 2012. That was a bit different to the musculoskeletal departments. And it's certainly different to how I was practicing in a musculoskeletal department, where I was still doing a lot of specific exercise prescription, let's say. So let's say quad strengthening for knee pain. You know, it was like, you know, oh, you've got knee pain because your quad's not strong enough. It was that sort of quite biomedical reasoning. And when I moved into the rheumatology department, I became very much more holistic. Whereas now, actually, you know, I treat most patients the same as I would a rheumatology patient. So I think from that point of view, I was lucky that I was sort of a bit ahead of the curve with regards to what was going to come, purely just because we were treating what were already long-term diagnoses, whereas back pain was sort of more considered maybe a shorter-term diagnosis.
Right.
So there was a bit of difference in there. I mean, I was lucky. I got to do lots of things, like I said, ordering blood tests, radiology, all those kind of things. I got loads of experience doing that, and that certainly set me up later. I suppose where my role is now is the patients that I see. I basically see second and third opinion patients for Tute's Health. So the classic would be, let's say, someone's been diagnosed with rheumatoid arthritis, they go and see a private physio, for example, and then that private physio thinks there are some things that physio could help with, but it's not my specialty. Yep. I have an appointment with the patient, they refer them to me. Usually it's one, but I do a couple of follow-ups maybe, and just as much as anything, refine the plan and help both the physio and the patient to understand what's going on with the condition and make sure everything is being done sort of as appropriate as possible, mostly because patients are scared because of their diagnosis. They don't really know what to do, but the physios don't really, because it isn't the most common thing to be dealing with. They just don't know how hard they can push the patient, what's appropriate, what's inappropriate for them. So basically I provide that information from a clinical point of view. And then, as you said, then I spend the rest of my time trying to absorb medical information and then regurgitate it in a way that physios can use. That's one of the things I found that I am good at, for whatever reason, is I take that medical side of things, put it through my physio filter, and then how do we then use that as therapists to help our patients sort of better. So it is fascinating, and it made me a way better musculoskeletal clinician. I'm not very good at rehab. It's not where my skill set lies. I'm much better in diagnostics and that kind of thing, which is what I've done over the last few years. And I found I'm much better at that. So I think if I was in rheumatology rehab now, I think you would find that my role wouldn't be that much different to a musculoskeletal clinic role, because musculoskeletal sort of has realized that general health and sleep and diet and all those kind of things has caught up where we were in rheumatology, and its impact on other conditions like back pain and osteoarthritis and stuff. So it probably wouldn't be that much different, except you never get rid of your patients really in rheumatology, because they come back around every 6 to 9 months or a year to see the rheumatologist anyway, and then they pop into physio and see you or whatever it is. So it's been an interesting evolution really, and watching musculoskeletal practice catch up almost. That's probably not fair, is it? Evolve. Musculoskeletal practice evolved to something similar to rheumatology practice, I think. And I find that what I've done personally is, as musculoskeletal practice has evolved to reach where I was with rheumatology, I've realized that actually I can push my patients way harder than I would have before. So you can use some of the back pain research and how people can tolerate exercise programs and that kind of thing, and apply it to an inflammatory population, and realize you can push these patients and they're probably going to be all right. So yeah, that's quite a lot of what I do now as well.
That's interesting. I think one thing that's sort of a stark contrast is this very broad holistic nature to it, that you're dealing with multiple systems, having to be aware of how those systems maybe interact as well. And I think from a point of view of physiotherapy, I'm kind of thinking back to how university prepares us for this, that you do cover those multi-systems and get a good grounding on those, which you then need if you want to then specialize in rheumatology, because you need that understanding and then that ability to be able to churn that out to a patient and to give them understanding on their condition. You need to have a higher level of understanding even more. So that makes sense. Yeah,
it's hard. It's really difficult because one of my favorite phrases when I'm teaching a course or whatever it is that we have rheumatologists for a reason. So I'm not aspiring to be a rheumatologist. We have rheumatologists. So it's like, and this is what one of the things I try and do with my website and resources and stuff is, what of all that massive information do we need to apply in physiotherapy? So it depends where you are in this patient's journey. So if you're in the recognition stage, so hopefully everybody's au fait with a first contact practitioner now, but if you're in that sort of role in a GP surgery, and the patient's coming to you without medical screening, they've never seen anybody before, so they haven't seen their GP or whatever, then you need to know about the relationship between inflammatory eye conditions, Crohn's, colitis, psoriasis. If you're in a rehab situation and the patient has been medically screened, diagnosed, then you need to know that those things are relevant, but you don't necessarily need to know their interaction to treat the patient. You'd be better off knowing specifics on how hard you can push them and those kind of things. So it's one of those things where you just, and this alludes to your question about why don't we teach it as much in universities as maybe we could. And there is only a finite amount of time and stuff has to get cut. And actually, I would say that if you go into respiratory or neurology, you're not going to see very much rheumatology at all. You're certainly not going to need to diagnose it. So you just don't need to know that immediately. But what I say to people is the minimum that you want to do when you get into that role where you're in MSK practice or you go into private practice, you need to be able to recognize that it is an inflammatory condition. Like that's the minimum bar. More than that, bonus, but the minimum is that you need to know that that's an inflammatory condition so you can refer them to rheumatology. It's an extreme example is cauda equina syndrome. We don't diagnose cauda equina syndrome. We suspect it and refer to A&E because we don't have MRI vision. This is the same. We need to suspect that it is that, refer appropriately, because if you're not, then you're just holding on to patients that you, one, won't make better, and two, delaying their diagnosis is going to be bad for them. So that's the minimum bar. And again, it's not something that people, I don't want students now to be thinking, oh, I need to know how to screen all my patients for rheumatology immediately when I leave university, because there's too much. There's, if I think about all of those body systems, if you just think about tendons, for example, we're already looking at, so you've got a rheumatological possible cause, obviously got a load cause, thyroid it can be related. Other hormones, especially in women, can be related. Fluoroquinolones, the antibiotics, can be related. So you're already at 5 or 6 systems just for tendons. You're just going to blow your mind. Like it's not the priority for a new grad to know all of those things. It's, you need to be good at communicating with patients and know when something's not right. And then everything else on top of that is a bonus as practice comes. So I don't want people to feel like that, but still people need to know the relationships that, you can't have, if you've got a patient with an Achilles tendinopathy or an apparent Achilles tendinopathy, you can't just talk about their foot. That's not enough. We need to talk about general health, other past medical history, family history. We need to know that those things are relevant, and then pick up things where you go, okay, well, that sets my alarm off. I'll go and have a clinical conversation with someone else, or I'll load up Jack's website and see if that relates to anything, and move forwards from there. And then you can start to build that case around it then. So, I don't know. If someone was if you said to me, should they teach more rheumatology in university? Obviously, I'd say yes. But then if they said, well, what would you cut instead? I would have no idea. Because not everybody, I don't know what the percentage of the physios are in MSK or rheumatology, but it's, we've got neuro and respiratory and all these other specialties. So we do need a broad understanding of everything to qualify. So, that's where I get stuck is, yes, teach more rheumatology because it'd make my life easier, but it would probably do me out of a job. Actually, I should say, shouldn't I? But I can't then cut anything. So, it's difficult, but hopefully that's where I come in and can make life easier for people, really. Once qualified, I think is probably the main thing.
I think and it leads back to, as a student, sort of knowing your scope of practice, knowing where you are in your learning, and that could be when you're a band 6. You always need to have that awareness. I think for a student, I've just recently caught up again on the rooms on YouTube, your videos, and there's a great video on there. I think it's about half an hour long for students, and it does really simply cover what you need to know, what you should be aware of. And I think, I certainly came away from that really thinking, okay, there's no pressure on me to become an expert in rheumatology. but I do need to, and I do have a responsibility to know just some simple things, a few extra questions to ask when I'm suspecting and when I'm treating those things. So I will put a link probably up here in a minute to that video, and do check that out, because I think it will put minds at rest apart from anything else.
Forgotten I made that, so thank you for reminding me. I think the thing is, you wouldn't expect to be, you know, an expert in everything. Like, I'm trying to think of another example off the top of my head, but with neuro conditions, for example, if someone came in with some weird set of reflexes, or some weird gait pattern, you wouldn't be expecting to be the equivalent of a consultant neurologist diagnosing the exact level at which they've got their neurological problem. You just recognize it's not for you, it's not an MSK problem, and you refer out appropriately.
Yeah.
And part of me worries that it's with this increased amount of knowledge that is accessible to students, new grads, that they think, like you said, scope of practice is the right term, that they think their scope of practice is way larger than it actually is, and they should know all of these things.
Yeah.
And, you know, if anybody watched me in clinic, and when I worked for Nuffield until relatively recently, and as an advanced level physio, where all I saw was complex spinal patients, so spine with referred pain, and multiple joint pains. But you know, if someone comes to me, if someone was ringing me up with a twisting knee injury, you know, I'm on the phone up to my clinical supervisors going, what's the mechanism of injury for an ACL or MCL? Like, that's not my specialty, is to know those sort of twisting knee injuries or sporting groin injuries. So I'd like to think I know more about rheumatology, but the rest of everything else is narrowed in a little bit, because you can't spend your whole life learning about everything. And this is coming from a guy who edits CPD podcasts for a living. So I do way more CPD, I would suspect, than your average physio, because it's my job to do it. And it's still not my specialty to be picking up those specific presentations. So you just have to be, like I say, getting the bar right on what you know and how to pitch that. And like you said, knowing what the difference between a new grad band 5 or an experienced band 5, band 6 into band 7 is, and where you're expected to practice. And that's really difficult, because it's not even a level playing field across roles either. So you could be a band 5 in one location where you're expected to do a specific amount. But if you were a band 5 in a slightly different location where the pathways are different, then you might be expected to do a bit more or a bit less, because that's the patient cohort you see, or the skill mix within your department. So there's not even an easy answer. And that makes it difficult with rheumatology as well. So you might be, let's say you go into private practice straight out of university, then I would say, you know, you've got to know way more than you would if you're in the NHS, because you are less likely, not unlikely, but less likely to have that clinical support in the next room, where you can go, oh, I've got this patient I don't quite understand. So it is difficult, and that does concern me with the new grads. You know, all of that, let's take Twitter, all of that information that's on Twitter, and you go, well, what on earth do I filter here to use appropriately? And, you know, we got people treating at sort of the cutting edge of what we would say is therapy. And then you've got poor new grads going, well, I've just learned my anatomy. How am I going to do all of this stuff in 45-minute appointments or 30-minute appointments? So, like you said, scope of practice is vital, and leaning on support networks is really important. So I think that's probably skipping ahead to what you've got a question about advice somewhere. That's some of my advice. Probably. I'm ruining your question scheme.
No, I usually ruin them myself, so you've just done it for me. It's fine.
Done it for you. But yeah, I think, you know, it is so hard. And I think, like we said, back when I qualified, none of this existed, and I wasn't bombarded with all this information. And, you know, I remember having clinical supervision sessions in my band 5 role, and, you know, they would they'd say, I'll pick something to go and read about. And, you know, I'd be into the search engines and, you know, PubMed, and doing almost like a mini literature review. And now all I do is sit on my phone, scroll Twitter, and find 10 papers that I'm interested in that I save for later. But you're getting machine gunned left, right, and centre with all this information, and it's filtering that appropriately. Is the challenging bit now. It's almost flipped completely around the other way.
Definitely. And I think, again, I think probably accurate to say we've touched on this on every interview that I've done so far. And I think going through the COVID pandemic and lockdown accelerated massively the amount of online stuff, which I think is really good. And I want to remain positive about it. However, you and every guest that I've had on as kind of given a bit of a warning to students, that there is a lot out there and not to feel like you need to know everything. But also to be aware of that filter of kind of, it is a lot out there. So just be a bit more careful about how much you try to absorb.
I mean, I think if I list off the number of podcasts I've listened to this week and last week, I can't retain all of that. And, I'm standing on a level where I've been practicing for 12 years. And I think it's hard because you've got to trust the sources that your stuff's coming from. So that's level one. You need to trust where it's coming from. But level two is you might trust where it's coming from, but actually it's not pitching at your level. And that's really difficult. I think about our podcast, Physio Matters podcast, and some of those are brilliant for students, and others would be just a step way too far, I think. And it's picking and choosing, and I'd almost say to students, like, you almost want to pick a trusted filter. So your podcast is a decent one, for example, or you've got CSP student Twitter feeds and what they put out, or we've got with Physio Matters, we've got a group which you're part of. I'm just plugging your own group on, Physio Matters First Steps, and those people who have walked some of the walk and gone, right, here's some mistakes we've made, here's some things we found that are really useful. Don't waste your time making those mistakes. And save yourself some trouble and use our filter that we've already created to help you. And I think that's a really good way of getting through it, rather than just following all these people on Twitter that you can follow, myself included. I tweet stuff that my recent blog is purely about psoriatic nails. And I wouldn't expect a band 5 to be looking at someone's nail beds when they've got tendinopathy. It's not. I'd rather they got a decent subjective history. It's about pitching at the right level and knowing what to read and what not to read, which is the real challenge now.
And I think it takes time, it takes confidence, but it's just, I think if as a student, just be aware of it. I think it's a really good one. And if you go back through the interviews, you'll see that every guest has said exactly the same thing. So if you can't take confidence from that, then well, please do. Anyway, right. So we jumped around loads, and it's just all great stuff. I just want to, just from a point of view of your career, because I know a lot of people that watch these are really interested in, maybe they're jumping ahead a bit, but kind of where their career might take them, because physio is hugely diverse. There's so much you can do with it. So kind of just these two questions kind of go hand in hand. What was your first experience of rheumatology? And then at what point did you realize that was your thing? That was your baby. That was where you were going to go.
I've had a funny old career, really, because I've done loads of different jobs. But what you also need to remember is when I qualified in 2008, there weren't jobs to go to. So it took me nearly 6 months to get a job after qualifying. I worked in a golf club pub for nearly that amount of time before I did any physiotherapy practice. And there would be the NHS jobs website, for example, there'd be 1 or 2 jobs come up a week. And one of them would be in Inverness or somewhere, and you see, I'll not apply for that. And then you'd apply for another one, and there'd be 200 applicants. It was really challenging. And my first job was a 3-month fixed term contract. So day one, I remember going in to that job, going home and applying for more jobs. So it didn't even stop at that point, because I was only there, I only had that contract for 3 months. So that was really funny, because then it took, I would say to do NHS rotations, it's going to take a little while if they're 3 months or whatever to get around them. But because I kept jumping jobs, because I had fixed term contracts, it probably took me 2.5 years to get even into MSK. I think it was 2 years before I even got an MSK rotation. So because obviously that was a really popular one, and because I was new, I kept getting bounced to respiratory or neurology, which, you know, I will talk derogatory about because I don't like doing it, but obviously that's other people's bag. But you know, I just survived on wards. I mean, you know, I didn't deserve paying really. I was so awful at it. But you know, it's funny, isn't it? But you know, so to answer your question appropriately, really, my first experience was that elective placement in rheumatology, and I was basically like, I do not want to go on another ward. I don't want to do any of that. So I was like, I want to go into outpatients and maybe experience hydrotherapy or whatever it was. I can't remember exactly what I did, and I ended up in in the rheumatology department in Exeter, which was amazing. Their rheumatology department is, I assume it still is. I mean, we're talking 14 years ago now, but it was really good, and the rheumatologists were so welcoming. So not even a medical student, but I'd sit in clinic with them all day, and they taught me through all these different things, and I was like, this is amazing. I want to do MSK was my thing. I didn't necessarily at that point think I want to do rheumatology, but I really enjoyed it, and that was great. Went off and, like I said, then did my rotations for a few years, and couldn't get into MSK band 6. I just couldn't. There weren't any jobs to apply for. So in the end, there was the hospital I was working at had a band 6 rheumatology post come up for a physio, and I applied for it, and I was the only applicant, and managed to be successful, fortunately, because had I not been successful, they must have thought I was really awful, because I was the only one who applied. So they gave me that job, whether I merited it or not. It might have just been a bum on seat, but never mind. And I did that for about 6 months before I suddenly realized that actually I had a bit of an affinity for it. The medical side of it I seem to absorb that much more easily. I don't do so well with the sort of biomechanics, but the so, you know, that sort of almost like engineering with angles and forces and things just doesn't fit in my brain appropriately. But the medical side of things, I have much better affinity for it, and explaining to patients as well. I felt like I had a better affinity for doing that, and that might be because I just didn't like the concepts of things like core stability and quad strength for knee pain and stuff. They didn't, for whatever reason, they didn't fit with my narratives in my brain. Turns out I was probably because they didn't fit the appropriate narratives. But that medical side of things was much better, and so I dug myself into rheumatology at that point, and then did that for another 5 or 6 years. I forget when I actually left the department in the end, because I went back. But that's what really got me into it, and I was sort of doing more and more and more CPD, and I was very lucky that the department were happy to send me off on different CPDs and let me spend loads of time with the rheumatologists, and we just had a very good department where we worked together, and I got to learn loads, and that really cemented it into rheumatology really, and then just fell into all this CPD stuff. So yeah, that's it really. But I then once I finished rheumatology, I then went, not finished rheumatology, but I didn't want to work in the NHS anymore, and decided I wanted to try and be a private physio, and was rubbish at that. So ended up doing that for a while. Then I went back to the NHS, but that was really good because I then got to work in an orthopedics department, which in purely foot and ankle, which again, I got to do really medical things, but onto a more specific location, which was really good for me because it meant I didn't only consider medical things, I had to consider biomechanics and that sort of stuff. And then, like I say, I ended up working for Nuffield, and that was remote work. Stop me if I'm going off on tangents here, but that was remote work starting a few years ago. So before all the COVID thing, we were doing those advanced spines and multiple joint pains on virtual consults a few years ago. That department's been running for years. So that really got me into the diagnostics and assessment point of view and management, because we got to do the overarching management, so we'd refer out for physiotherapy. So that was really fascinating, and also was my ideal job because I got to do all the diagnostics workup and then just refer out for any of the rehab, which is what I suck at. So, and then just get people back and they'd be like, oh, my physio isn't working for whatever reason, like, you know, or my physio is brilliant, it worked like a charm, and you see patterns of what works and what doesn't, and demographics of what works and what doesn't, because you see so many of these diagnostic patients. And that was really fascinating. And then, left that in order to do more of the CPD stuff. So my courses and working with Choose Health, Choose Media to create Therapy Live, the conference, and the podcasts, and we've got more podcasts coming. And you know, that is really, I feel like, where my interest is currently. And then I still do the second and third opinion work with rheumatology patients. So I've really been able to, I've been very lucky with being able to pick and choose what I've wanted to do, and suit my learning needs as a job. I've been really lucky. I feel like it's sort of karma for the fact that it took me 6 months to get a job in the first place.
I think when you say you've been lucky, I think one of the things I love about physio is the opportunities it gives you. You have to go out and get them, and you have to, you know, take those opportunities, which I've spoken about before in other interviews, but they are out there. And I think one of the things that's kind of shows through with what you do is that you found something that you really, really love and enjoy. And I think that's the key, is when you do that and you find that, you usually are then exposed to more, because those are people who are working around you want to nurture you and help you and support you, which you sounds like you've had that in your career, because people around you have recognized your desire to kind of do what they also love. And it's quite clear that's kind of been the route. So those watching, who, I think there'll be some people who still have no idea what they want to do with physio. I think that's a majority. There's you know, you'll find it, and when you do, it'll drag you along like a train, I'm sure.
Yeah, and to be honest, that's one of the great things about how much CPD is available now, is you could look, let's say you started on your rotations and you do a few, or whatever it is, whatever job you end up taking up to start with, and then you can dip your toe into different things, and see what you like, what you don't like. I'm one for challenging myself and I always want to do the next thing that's really difficult. I want to be able to, and I think that's why I'm not very good at rehab, because, you know, it's all everything's very grey in rehab these days. You know, when I qualified, it was if you got back pain, you do some core stability work and improve your posture. And now it's all sleep and mental health and general exercise and body weight and diet and everything. And it's very grey, and that fits brilliantly with a lot of people. And for some reason, I do that day in, day out with a rheumatology patient, but give me a back pain patient who doesn't have those rheumatology problems, and it doesn't float my boat at all, and I get very bored very quickly. And I was able to challenge myself really a lot, especially with things like, I've been into private practice, like I said, and I just don't suit private practice at all. For whatever reason, I'm not sure what it was. I think it didn't sit well with me doing sort of insurance work and those kind of things, where people already had, like, I'd see people who had 8 sessions for physiotherapy and they'd be better after 2, and I start to fill the next 6, and I'm like, this isn't what I want to do. And then on the flip side of that, you'd have someone come in and they had back pain for 2 years, and they want to be better in 1, and you're like, well, that's not how it works either. And I felt very disillusioned by that. It didn't settle. So I was then, this is where I was lucky, is that when I was thinking, I don't like this private practice malarkey, then I was able to go back into the NHS and do the orthopedics work, which really set me onto the diagnostics side of things, because the timing just happened to be right. But like you said, I think I'd set that stall out at that hospital. Every time opportunities came up, I was the one saying, I want to do that.
Yep.
There's 2 or 3 extra hours on a Tuesday night to see see the NHS staff, or it's occupational health work, and I'm like, I'll do it, or whatever it is. And then they go, oh, would you like to do this orthopedics work? And I'm like, yes, I'll definitely do that, because it means I can leave this private practice immediately, and go and do that. And then that allowed me to then get into the Nuffield job, which was sort of my perfect role for a few years, really. So I think there is some luck and some seeking, like you said, and it's about, I think, for me, it's about finding opportunities where I didn't think there was some, and really challenging myself and finding that next thing to try and be good at. And then sometimes like you said, failure it can be something to learn from. I thought private practice was where I was going to be happier, and I was absolutely not happy there at all. And you've got to take the rough with the smooth, I think, and manage things that way. And now I get to do, well, pretty much whatever I want, really. So I've paid absolutely terribly. I mean, there's absolutely a pittance in podcasting. But I mean, if I got 3p, then I'd be very happy. But I make enough money to pay the mortgage and read all the journals and write random stuff about rheumatology that I like, and that suits me perfectly fine.
Yeah, it's the important things in life, isn't it? At the end of the day, yeah. And
I work a lot at night, talking to people like yourself.
Yeah, and it's sharing things with like-minded people, and it becomes an enjoyable pastime rather than a job, doesn't it? Almost.
Exactly.
Which is great. I don't want to dwell on this one because it's all been quite positive, and I think it is a key one because I'm sure there are things. Some of the frustrations that you have around physio and rheumatology, and it may link back to some of the things we've already talked about.
Yeah, I think the main thing for me is when I teach courses and I find that the base level is not where I thought it was going to be, if that makes sense. Yeah. So I always start with every course that I do, and I think I did it on that video that you talked about for students. I always start with what are the symptoms of inflammation, and the number of times where I don't feel like enough of the crowd, for want of a better term, knows what I'm asking, that really frustrates me, because I think you should know what the symptoms are, and you should know what the symptoms of inflammation are. And that all rose from when I was in the NHS. I did some junior interviews, some band 5 interviews, and that's the question I asked them. I thought that would be easy as hell. I thought that would be very easy for them to get, and it would open up questions to what would you do with inflammation, and if you thought the problem was from inflammation, not from a rheumatology point of view, just from a sprained ankle or whatever point of view. And I was appalled, is the wrong word, very surprised at the lack of answers that I got for what constituted inflammation. And it's not like they were all from one university and so it was just happened to be skipped on that course or whatever. It was from a variety. There were enough of them to make me worried about it. So I put that into my courses, and then that problem sort of continues. And that's what worries me, is this lack of general knowledge about how things affect the body. So what happens if this happens, what happens if that happens, especially on the musculoskeletal system, because that's what we're supposed to be specialists at. And then I don't expect people to know, I mean, this is why I teach the course, I don't expect people to know that for example, if you get diagnosed with colitis, you've got about a 25% chance of developing an inflammatory arthritis in the next 6 years. That's not what I expect people to know. That's what I then teach them, that's a very big risk factor. But I would expect them to know that other inflammatory conditions exist, and then we'll teach them the relevance. But that's not what really happens. So that's my biggest frustration, is I think people are very quick to go and learn flashy things, or go and learn I don't know, what am I thinking of, like CBT, or I'm trying not to pick on manual therapies or acupuncture or something, but even other things like these psychological therapies or advanced assessments, all this kind of thing, and then they can't name features of inflammation. Like I ask them, if you had someone with a sprained ankle, what symptoms would you expect them to have? Redness, heat, temperature, and swelling, and they don't even get that. And I'm thinking, pain, exactly. What are you? I don't get this mindset that we're stuck in. And I part of me, like we said earlier, what I worry about sort of the Twitter sphere and Facebook, and this pushes people into these higher level courses. But it's get those things right first, and then we'll build on top of that. So I spend the first hour of my course usually going over some relatively basic concepts to make sure everybody's at the same level. And that's what I would say to, students and new grads is just learn biology to start with. And then it all makes sense after that. I mean, I've been lucky enough to attend immunologists' talks on immunology, and it blows my brain and it all comes out of my ears. But then once you sort of start to understand what the immune system's doing, you understand what then happens with inflammation. Why does that then give you symptoms that you get? Why does osteoarthritis occur is relatively obvious once you understand how the inflammatory process happens. And so relatively obvious, that's way oversimplifying something that science doesn't understand, but it makes more sense as to why it's not purely a load, like it's not wearing out like a car tire. It's a completely different process. And so I found that those kind of things, learning those kind of things, has been much more useful to me. And some of that's been luck rather than judgment. I was booked on an acupuncture course once and couldn't go and never went and did it. What a waste of my money that would have been. And I'd much rather have done something else, but I would have made that mistake had some other thing not got in the way. So I think people need to try and keep things basic, and then the learning comes into play.
Yeah, definitely. I mean, I actually kind of rings true on what we used to get taught at the University of Plymouth is the foundations of learning. And you always used to get taught the cake, make sure you get that sponge first before you start putting the icing and the cherries and all the fireworks on the top. Because if you haven't got that sponge, it's all just going to collapse in anyway. You can use a house as an analogy for that as well. But it's just so true. If you haven't got those basics, you will some way along the line either find it harder to get some of those big, more complex things because you won't be able to put them in context with some of the basics. And I know from my current rotation in medical rehab and working with healthcare of the older people and things like that, is those basic body systems. It's really, I've had to go back to some real basics just to be able to get my head around some of the conditions that I'm seeing. And I think, so I think it's really important. So that's good. So kind of moving on, I'm sure this is all going to link together. We're starting to now think, okay, the audience that we've got watching this, and hopefully there are some band 6s, band 7 and band 8s watching this as well, because I think it's really, really good to know what students are watching and things. But for students, what would you give in terms of tips? So we've picked 3 things here that you'd be advising students or giving them as tips.
For rheumatology or general?
You choose.
I choose. Let's go for rheumatology then. So because that's why I'll force any conversation to rheumatology if I can. So I think from a student point of view, being aware that these conditions exist is, especially if you're looking at becoming, if you're a student and you think MSK is where I want to be, I think you need to know that these inflammatory conditions exist. I would hope that we're aware of, or the students are aware that things like cauda equina exist, spinal cancer exists, that these weird and wonderful things that are within this 2 or 3% of what causes these symptoms, that they exist. And I think that's number one, is just understand that they exist and that they masquerade as musculoskeletal conditions. The second tip that I would give is just when you're thinking about assessments, is just make sure that you're really thorough with regards to the whole person. This might not be the case all the time, but when you're a student, you get more time to be with the patient. And I think I certainly remember when I was a student, I just wanted to get on to, let's do some exercise, let's do some rehab, let's make you better. Let's improve things for you. But actually, that's not really that useful. I think it's far better to be like, right, get all the information that you can get about this patient. The better the assessment is, the better you can make the treatment program, I think. And so much of that is from the subjective. The more and more we learn is that our objective testing just is either not that accurate or not that relevant. And it is important to do, and it is important to touch and feel and move. but not as important as listening to the patient and hearing what they've got to say and listening to their symptoms, but also getting that information about what their general health is like, what their family history is like, what their other conditions are like, so that you're getting that, like you said, foundations is great. You get the foundations of a subjective assessment, that then later you can learn how all those pieces fit together. And you can learn, like I said, that colitis will cause an arthritis within 6 years in 25% of patients. And then you know that when you've got someone in with multiple joint pains and they got diagnosed with colitis 2 years ago, that starts flagging up in your head, that you should be really digging and trying to rule out these conditions before you think about whether you should be treating them or not. So how many have I done? I don't even know. How many tips? That's 2. I've got to go another one. Go on my website. Is that a tip? I think it would be that trusted resources thing, actually.
Yeah.
Whether it doesn't matter whether someone says mine's trusted or not, but find, and it's individual to the person, find where you have trusted resources. And that doesn't necessarily mean a trusted resource that you agree with. It might be that someone's providing a different point of view to what you're being taught or whatever, but as long as you have it trusted. So, what I would do is think, like we said before, either get that from some of the student groups and things that are already available, use their filter, or with your friends and colleagues to use the filter. It's very difficult to make that decision on your own, but to have those other filters and try to expose yourself to other ideas as well, because you can't be reliant on either the university or your supervisors or whoever to give you the correct answer, because that's one point of view, and like I said, a lot of stuff is grey, so it is worth getting some other points of view and some differences, and it does end up being grey, and that's the wonderful world we live in. So I think that would be tip number 3.
I think tip 3 is a good practice for being a physio, because there is almost never one right answer, and there's always going to be different opinions, and formulating your own ideas is really important, and being able to simulate other things that you're getting, and also being aware that it's going to change at some point. It's going to change. Tip
3.5, don't hang on to things. But I think one of the things that I talk a lot around when we talk about planning podcasts and all that kind of thing is we try to argue other points of view that aren't ours as if those ones were correct, and then that helps you to see where those arguments fall down. So or yours fall down. So let's take acupuncture, for example. I try to, if someone's talking about acupuncture and I disagree, I try to argue their point with myself and see what comes back. And either I'll come up against something that I don't know, which is quite regular, in which case I might go and research that, or I might think, actually, I better leave their point alone because I can't argue against it because I don't understand some of it, whatever it is. Or it doesn't fall down. I can make an argument. Maybe they're not making the argument, and I might parrot that back to them and say, well, look, maybe you think about this way, or whatever. But that's a really interesting thought exercise, is to try and argue a different point of view from your own and see what you come up with. And it stopped me a lot from getting embroiled in Twitter conversations that don't go anywhere, because I used to do that loads, used to sit up all evening arguing with someone, and it's not worth it. And there is, like you said, there's loads of grey, and we all sit somewhere within it. And you pick what you want to do, and make sure you know as much as you can about various things, and then you can make an informed choice as to, you make an informed choice about whether you want to go on an acupuncture course or an injection course, or because steroid is clearly an active ingredient, but do you want to put steroid into someone's joints? Maybe not. So you want to make an informed choice, not one because you think, oh, that's a good skill that I could charge for or whatever. It's hard. It is hard. And I sort of in some ways envy students now because of the amount of information. And in other ways, I'm like, thank God that wasn't around, because I was crap at written assignments before. Never mind now, I'd be awful. I'd be absolutely woeful at it. So yeah, far better now. I could just write about one very, very narrow topic.
I think I really like the idea actually of if you're going to spend some time doing a course, doing some e-learning, or even spending a bit of time reading a blog, is having an idea as to why you're doing it and what's your reasoning for. I'm going to look at this because, and then it might just be a good little task. Actually, I'm going to use that next time I spend some time on something. I'm going to say, right, I'm going to do this because. And what's my reasoning behind it? And that's a good one. Just another one to touch on again, for those listening to this who haven't listened to any of the interviews, I love the fact that we've gone back again and talked about subjective and how important the subjective is. If you have watched them all, hopefully now you can see that the importance of subjective is just, it's massive. It's just so key. And it's the thing as a student, I know I did. I rushed because I wanted to get to look at someone's knee and then I wanted to make that knee better. But actually, it was all the stuff you asked beforehand that really enabled you to make that knee better, or that person better.
For sure. And if anybody wants a prime example, is like we said, my Nuffield job was entirely predicated on a subjective assessment. There was no there's no video, no objective assessment at all. And that was what the equivalent of an ESP role. So like band 8 or whatever. I couldn't do a Lachman's on a ACL deficient knee because of I can't reach the screen and do it. So theoretically, it is doable entirely off the subjective. Now it does have its own problems, obviously, it's really hard to assess redness over the telephone. But I think it's still undervalued, the subjective assessment. It should be, people should really concentrate, or physios should really concentrate on that, and they will find it invaluable the better the subjective they can get.
I remember one of my educators, I'll never forget, said to me, she said, if you see a patient and all you do is the subjective and you leave them with just something to go away with, but you've cleared them from anything serious, she said, I'm happy with that. If you get that bit right, because next time they come in, you will have a far better appointment. And it just took all the pressure off me. I don't think I ever did just do a subjective with a patient, but it just took the pressure off.
I've definitely done it. Even ignoring that Nuffield job, I've definitely only done subjectives before.
Yeah.
Definitely. And then it's just the way because people will go, oh, we're not going to do anything else. You just say, well, I just want to be able to help, and this is how I think best to help. It will help. You just need to frame the conversation appropriately, and you just say, we'll bring you back and we'll have a look at how you move and do some things next time, and then we can move onwards. I think that's perfectly acceptable, and as long as it's framed appropriately and you've got the support of your department or colleagues to do that kind of thing, then that's a decent department to be working in.
And 100%, definitely. So again, we probably covered this a bit. What can new grads? So we're talking about new grads here. So you've gone through your degree, whether that be the 3, the 4, the 2-year pre-reg masters, etc. What advice do you give to them for upskilling in rheumatology? I think it's probably important that actually take on board what we've already talked about. But is there anything specific that you think?
Yeah, it sort of depends. Yeah, it depends on where their where they fit into the patient pathway. So the nearer they are to the beginning of the patient pathway, the more they need to know about recognition. Yeah. The further down the pathway they are, the more they need to know about the rehab side of things. So wherever you fit on that spectrum would be my suggestion. The more medical screening they've had, the less likely you are to get a rheumatology condition filter through, but they still happen. And it's about making sure, and that, if we went back to my tips and I could do a tip 3.6 is always do your own assessments as well. I think you just don't rely on what other people have done, because people miss things and we're all human, and it's something that we all need to be aware of, and I think that would be where my tip would be for a new grad. If you're in an MSK department, it's about knowing your place within that patient journey. And if you might be in an MSK department. We used to get, when I worked there, patients come around from A&E for various reasons. So they'd be right at the beginning of their healthcare journey, or we'd get people who'd been to various other locations before getting to you. So you're further down that healthcare journey, and it is an important distinction. And like I say, the less medical screening, I would say if your patients are only coming with a GP screening, then you definitely need to be well aware of what's happening with regards to the different systems. If they've come through from GP to through an musculoskeletal assessment clinic, or whatever the equivalent, MCATs or CATs or whatever it's called, into orthopedics and then to you could probably be a little bit more relaxed that 3 people are less likely to have missed it than 1, but still you still need to have that hat on a little bit. So I think that's what my advice would be, and just try to be the best clinician that you can, really.
That's a good one, isn't it?
Not a perfect one. I mean, I'm rubbish, really, apart from this one very narrow area.
Just being honest with yourself. That's the other one.
Yeah,
brilliant. Sure. I think that's really good. I think, and it's a good one for new grads to have, to take away. And I think that's quite nice the way you framed that, in terms of being aware of where you are on that patient journey, early or later on, and think of it like that in terms of what you might need to upskill on. That's fantastic. So we've got the standard questions now, just to kind of wrap things up. So the first one is a golden oldie. So it's a research paper that it can be as old as anything, but you think remains quite important to your clinical practice for whatever reason.
Yeah, I think it wasn't that massive, but there was a study done in 2016. It might be slightly earlier, it might be 2014 or 15, done out of Norwich, and that was one of the ones which showed, or most recent ones, which showed there's still a huge delay to diagnosis with inflammatory back pain. And they showed that it's been slightly updated now, so we've got slightly better data, but they showed it was about average of an 8.5-year delay to diagnosis for those patients. And that made the framework for how I now teach what I call recognizing rheumatology. Most of the things that I get asked to talk about is that, for that reason, is because the delay to diagnosis is so long. They showed, so this is in the UK we're talking about, so but it has been shown similarly elsewhere. People would have seen somewhere between 2 and 6 clinicians for their back pain, and over that 8.5-year delay, and people will progress significantly in that time. So we know that it's the longer you wait for your diagnosis, the worse your outcomes are across almost every measurable variable. So bringing that delay down is very important. Now, there are some parts of that delay which are not necessarily our responsibility. The patient has to attend to the GP or the physio or whoever. You don't know, patients don't exist if you don't know they exist. So there's some work to be done there, but certainly I use that to say, make sure it's not you, it doesn't get past you if it's there. These conditions aren't easy. You're going to miss some. It's missing as few as possible, and being as good as possible, really. That's what I've built. I nearly said that's what I've built my career off, but that's certainly what I've built my social media presence off, my course presence off, is basically off the back of that. And like I say, there's been some more studies since about where the problems lie, what skills people have in recognition, and some more subset data about who gets delayed for how long. But essentially that hasn't changed as far as we're aware. It's still that long to get diagnosed, so we need to improve that. That certainly changed my career anyway. Well, I adapted my career to pursue that.
Yeah, and it heightens that priority of needing to be, like we've said all the way along, just having that certain level of understanding to be able to ensure that you're not the one, where possible, to delay that diagnosis. So
yeah, exactly.
So what about a recent one, something that's just cropped up that you thought, actually, that's changed my practice?
I saw a paper last week, and they'd done some, I think, you have to bear with me if I get the details ever so slightly wrong, but they MRI'd, I think it was thigh muscle bulk in newly diagnosed inflammatory, I think it was rheumatoid patients. And they showed that prior to diagnosis, they'd lost both power and muscle bulk. So that will change my practice from when I start teaching, and it did because I taught on Sunday, is that it's now my opinion is it's now not enough to recognize that they've got an inflammatory condition. We also need to educate them they've got to start exercising even when we make in the referral for diagnostics. So
early on.
I thought I was asking people to do too much as it was. Now I'm going to ask them to do more. That it's now probably not enough just to refer to rheumatology, but we probably need to give them activity guidance as well to try and it's probably too harsh to try and get them to regain muscle bulk, but to reduce the loss of muscle, so that their function can be as good as possible and they have a better chance once diagnosed. So yeah, really fascinating stuff. So I apologize to the writers of that article, as I don't know who it was to hand. I think it
we'll put the links to everything.
I remember who did the tweet, so I can find it. Okay, I'll give you the link to that. But yeah, really fascinating. And again, it pushes me with things like with osteoarthritis and diabetes and all these other conditions which cause systemic inflammation, that we've got to get people exercising more. And I have this problem with activity versus exercise, where I just don't think activity quite cuts it. It's got to be enough load to create an adaptive change. And I think this again has pushed me towards that exercise load, which is appropriate for the patient, but we've got to create that adaptive change. So I wasn't expecting to have my practice change that day, but it did.
No, that's great. And it's good, after, X amount of time working, you still, every week or every month, you're going to find something that's going to, or should change your practice regularly. So you then progress as a clinician. And I think it's important for students to know as well. Let's go with a question I haven't prepped you for. It's a nice easy one. If you weren't a physio, what would you be?
I've always said, in contrary to the original answer I gave earlier, where I said I didn't like angles and forces and things, I always thought that if I hadn't done physio, I would have done engineering. I've got a brother who's very successful at his engineering job. He's quite a lot younger than me, but he's very good at engineering, and we're very similar. So I've always thought, I could, how you look at people and you think, I could do that, but actually I probably absolutely couldn't. Originally, I remember when I was much younger, I wanted to be a vet, which is ridiculous. Not really a fan of animals at all, so that would have been really stupid. So I'm not really sure what I'd be if I wasn't a physio. I think I'm quite happy with what I ended up. I probably would have done something with computers or IT. That's what I found. I'm pretty good with editing and audio editing and video editing and stuff. So maybe I would have found my way into that.
But physio enabled you to find that way as well. So
exactly, yeah. Again, luck or judgment, whichever way it was, I've managed to get into that and do that quite a lot. So always good fun.
I always think physio is a great facilitator. It gets you into everything. So last question is, actually no, it's not last question. I've just thought of two more. But before we do those ones, recommend us something. It can be anything at all: a book, a film, an experience.
My immediate knee jerk is coffee. I think if you want to be successful in life, you've got to love coffee and get you through any situation. Good espresso, get you through any situation. That'd be my suggestion.
Current favorite coffee at the moment, because I know you're a.
This is an absolute shameless plug for YooHoo Lifestyle. So if you type YooHoo Lifestyle, is it the letter U, then WHO and lifestyle? Get coffee from there. They do a bean called Kurt, which is it's my good friend Tim who does these different, he attaches music to coffee beans, and that is a very nice coffee. So everybody should go there and buy Tim's coffee, because that's amazing. And he has Spotify playlists which go with the coffee and stuff, which is right on my street. So absolutely, everybody should go and do that.
I just love the way that I'm seeing almost as much passion for you talking about coffee as rheumatology.
If I didn't have coffee, then I would have no. I've just finished my Pickle Rick mug, coffee before we went live now, and I don't do anything in the morning before I've had coffee, and I'll do it all through the day.
There you are. There's your tip. Biggest tip.
It's
tip
a bit like drugs. That is it. What do I advise? Drugs.
Oh dear. Okay, so I'm going to do 2 quick fire ones now. No. Yeah, no. 2 quick fire ones. I'm going to cut that out, I think. So, cats or dogs?
Oh, can I go neither?
You've got cats
and dogs. Well, my girlfriend does. Can I have a stuffed one? That'd be my preference. One that doesn't need feeding or clearing up after, and doesn't get hair.
I shouldn't have asked these questions because you just said to me a minute ago you don't like. You're not that big fan of animals.
Yeah, I know. Shocking.
Which would you rather, a pet cow or a pet horse?
Oh, a cow, hands down. Do you want a reason?
Yes.
Well, I can have milk out of it for one, and then I can make burgers later.
It's got to be the best ending to one of these interviews that we've had so far, I think. Fantastic. Okay, brilliant. Well, thanks so much, Jack. Just as, again, everything that we've spoken about that's got any links or any resources, I'm going to put in the description down below for this. Just before we wrap up completely, Jack, just want to let the viewers know how we can find you and where we can find you.
Yeah, easiest way is to go to my website, rheumatology.physio, find anything there. There's blogs which I write every now and then. I'm trying to do one every week, but that's going to fall flat very quickly. Like you said, there are some resources on there as well in my shop, which I do have to charge for because they cost me to print. But I've got an online course there as well. Probably more appropriate for band 6s. Onwards than a new grad, really. The blogs would be sufficient for new grads, I think. But yeah, I'm on Twitter, rheumatology.physio. I'm on Instagram if you want pictures of coffee. Again, rheumatology.physio. Unless you tag me in something, then usually then I'll be on something physio probably. You're the only person that tags me in anything on Instagram. And I've got a YouTube channel. Yeah, YouTube channel, rheumatology.physio, and I try to put those things on a podcast as well in case people don't want to watch it, they want to listen in the car. So just rheumatology.physio on any podcast player, and you can listen. I try and read my blogs out as well so people can listen to them.
Great stuff. Brilliant. Well, Jack, thank you so much for the time this evening. I think it's been a really good insight into an area that students may not have had so much exposure to. So thank you very much for myself and behalf of everyone watching this. And I'm sure, I think maybe in 2021, we'll get you on again and so talk in depth, maybe a bit more about rheumatology or even pet cows, whichever one we choose.
Yeah, either. I'm always, if I've got a microphone in front of my face and I can talk, then we're all good.
Brilliant. All right, thanks very much, Jack. Catch up with you soon.
No worries. Thanks, James.